Hello and welcome, everyone. I am Jessica Petrie. I am Associate Director here at Kornhauser Health Sciences Library and head of our Clinical Services Program. Thank you all for joining us for this installment of our Diversity in Healthcare discussion series. In addition to all of our many esteemed panelists, which you'll meet in just a second, we also have one more very special guest today who I have the honor of introducing. We have the Diversity, Equity, and Inclusion Coordinator for the University of Louisville Libraries and co-chair of the University Libraries Diversity and Inclusion Advisory Group, Renisha Chandler, with us today as our guest moderator. So Renisha, thank you so much for joining us, helping with all the planning and agreeing to guest moderate for this session. If you are ready, I will go ahead and turn the floor over to you.
Thank you, Jessica. I appreciate this opportunity and I look forward to the evening and the discussion that we have with our esteemed panelists. Today we have 4 panelists joining us for this, what I believe to be very engaging dialogue this evening. I will begin with Dr. Simone Lavelle Bruce. And after I do each bio, I will give the opportunity for each panelist to get the opportunity to introduce themselves. Dr. Simone Lavelle Bruce earned her doctorate from Spalding University in Louisville, Kentucky. She completed her pre-doctoral internship at the University of North Carolina at Charlotte, and serves as a postdoctoral fellow there as well. Dr. Bruce holds a master's degree in clinical psychology from Spalding University and a Master of Science from Capella University. She received her BA degree in psychology from the University of Kentucky in Louisville, Kentucky, and Lexington, Kentucky, Dr. Lavelle Bruce is highly knowledgeable of mental health issues associated with racism and discrimination, having completed her dissertation on the psychological and physical association of race-based trauma among racial justice activists of color. She practices from a social justice-oriented lens and is passionate about recognizing the impact of race-related stress on Black and Brown communities. Dr. Bruce has facilitated talks and contributed to the psychological literature on topics including OCD, hoarding disorder, and race-based trauma, and has served as an expert on race-related oppression for various media sources. As a supervisor and trainer, she recognizes the importance of culture and identity and strives to educate others on a delivery of culturally responsive care that prioritizes diversity and multicultural differences. Dr. Bruce.
Thank you so much for that introduction, Renisha. I'm not going to add anything to that. I think that was perfect. Thank you all so much for inviting me to participate in this important event about the COVID-19 vaccine and the factors that make trusting this vaccine difficult for the BIPOC community, particularly Black and African-American people. Something that I've heard from scientists, healthcare professionals, and the current Biden administration. I've heard them say in the media that, that they want to ensure that access to this vaccine is equitable. So it's this idea that people groups who historically have not had access to proper health care or who have been more likely to receive inadequate care will have just as much access to this potentially life-saving vaccine. So on the surface, this sounds good. And this is what people of color have been fighting for decades, right? Is, equity and fairness within not only the healthcare setting, but within various arenas such as the criminal justice system and education arena as well. So I think on the surface, the messaging that the BIPOC community will have equal access and will not face the systemic barriers that have prevented adequate healthcare sounds wonderful. And this idea that we should trust the science may be comforting to some, but what must be addressed and acknowledged is the decades of systematic oppression and institutional racism at the hands of the medical community on Black and Brown bodies that continues to plague our community today. And these abuses continue to perpetuate that mistrust. Historically, we know that our bodies have been used as guinea pigs so that doctors could use them as experiment subjects, most notably during enslavement. And so that mistrust is extremely valid. There have been studies done to understand medical mistrust, and the research shows that people of color are aware of the medical health disparities and the impact of poor care by medical professionals, which is largely made up by white professionals. Studies show that Black people appear to have greater distrust of the medical establishment as well as mental health care establishment, many believing that medical institutions hold racist attitudes. Other studies have shown that these negative perception of the medical field may be rooted in the historical abuses which occurred during slavery. Implicit bias causes health complaints and bodily discomforts to be taken less seriously and dismissed, which subsequently has led to little or no treatment for serious health conditions, particularly when it comes to Black women. A vast majority of the Black community and many others know about the Tuskegee syphilis study, which was a US government sanctioned study that was designed to observe the natural course of untreated syphilis in several hundred Black men. And adequate treatment was denied from these men, and many suffered and died as a result. That study ran for 40 years. We know that pregnancy, for example, is more dangerous for Black women than for their white counterparts. And a CDC study found that Black women are about 3 times more likely to die from pregnancy-related complications, even when controlling for factors like education and income. And a central factor for this disparity has been linked to racism. So all of this prior knowledge leads to medical mistrust of this vaccine, and sometimes something that it leads to what we call a healthy paranoia, which refers to a feeling of defensiveness and distrust against a genuine threat, even when other groups might find the skepticism to be ridiculous or even trivial. So we have to remember that when people of color, particularly Black people, are bombarded with messages that they must take this vaccine, that we are carrying and holding in our bodies the trauma of numerous encounters of discrimination and racism, and that, this is not only happening now, but even from the past, because trauma, in this case, race-based trauma, is intergenerational, and studies are exploring this idea of passing trauma down from one generation to another. It's important to mention that these abuses do have stark mental health consequences, which can include the development of PTSD, stress, anxiety, depression, substance use, and severe psychological distress. There's also a link between racism and physical health problems as well. The human body's response to repeated stressors, such as racism and discrimination, have been linked to chronic and deadly health conditions such as high blood pressure, heart disease, kidney disease, and a weakened immune system. It's important to say I do not speak for the entire BIPOC community as a whole, and as we are all different and unique individuals, but a vast majority within the community share a common experience of oppression and mistrust toward the field of medicine for the reasons I've outlined previously. However, what has been helpful has been the representation of minority scientists, researchers, and healthcare professionals who have lent their expertise in the development of this vaccine, as well as those who have led by example by taking to the media or to their social media platforms to share their own genuine trust in the science behind this vaccine. As the medical field becomes more diverse, I think that, and as the faces and images we see representing these life-saving interventions, such as this COVID vaccine, become more representative of our population, we may start to see a decrease in this medical mistrust and stigma experienced by the Black and Brown community. Additionally, an acknowledgement of the abuses that have occurred and measures taken to provide culturally responsive care can also facilitate healing and trust between communities of color in the medical field. I can say that, the speaking and consulting with Black medical professionals who shared their experience of the vaccine and their trust in the science with me helped me to make an educated and informed decision to take the vaccine. I did, in fact, take the vaccine this morning, and I do feel confident that I did what was best for myself and for my family. Thank you.
Thank you, Dr. Bruce. Next, we will have Dr. Mark Burns. Dr. Mark Burns is an associate professor in the Department of Medicine with the University of Louisville. He earned his doctorate of medicine with the University of Louisville School of Medicine in 1988 from the University of Louisville in Louisville, Kentucky. He continued on to have his residency at the University of Louisville in internal medicine in 1991 in Louisville, Kentucky, and proceeded to have a fellowship with the University of Louisville Hospital in infectious disease in 2017. Infectious diseases is Dr. Burns's current specialty area and area of interest. You'll be hearing now from Dr. Burns.
Thank you, Ms. Chandler, and thank you. It's a pleasure to join you and the other esteemed guests on the panel today for our discussion. I want to mention that our present pandemic from COVID-19 has resulted in the largest physical and economic disaster of this century. Vaccines are now available, and it seems that there is a potential endpoint for this catastrophe. However, it does appear that there is reluctance among the minority communities to take the COVID-19 vaccines. For a brief history, on December 31st, 2019, the Chinese health officials reported a cluster of acute respiratory illnesses in the city of Wuhan, China. The Chinese officials confirmed that a novel coronavirus was associated with this. By the end of January, the first person in the United States was diagnosed with what is now known to be COVID-19 from the SARS-CoV-2 virus. And to this point, there have been several million cases that have been diagnosed worldwide. And in the US, unfortunately, there have been well over 500,000 deaths. Several vaccines have been in development for many months prior to this. And on December 11, 2020, the Food and Drug Administration approved vaccine from Pfizer and BioNTech for emergency use authorization to help combat this deadly virus. This Pfizer vaccine was shown to be 95% effective in preventing illness by the coronavirus in clinical trial participants. And it was demonstrated amongst different age groups, different races, and people at different health risks. The COVID-19 vaccine, another COVID-19 vaccine was developed by the pharmaceutical company Moderna, and it was 94.5%. And it also showed its effectiveness against the coronavirus during clinical trials, and was approved shortly after the Pfizer vaccine. Now, due to longstanding health and social inequalities, mostly in the minority communities, there has been demonstrated reluctance to be vaccinated among racial and ethnic minority groups. Coincidentally, it's been noted that COVID-19 has been disproportionately affecting these minority groups with higher causes of morbidity and mortality. According to the Pew Research Center, which is a nonpartisan think tank group in Washington, D.C., in January of 2021, they noted 60% of Americans said they would take the vaccine for the coronavirus. However, only about 42% of Blacks said that they would get the COVID-19 vaccine when it was available. Reasons for reluctance and what is now known as vaccine hesitancy was given when several interviews amongst the minority communities were conducted. The major reasons for this reluctance included situations involving, first, Henrietta Lacks and the revealing of her name publicly, along with the giving of her medical records to the media and publishing her cell's genome. They were later known as the HeLa cells, which actually benefited the medical community and helped in research in many projects, from polio vaccines to the AIDS vaccines, and even up to the coronavirus vaccines. The major event, however, when asked about vaccine reluctance, that was usually referred was mentioned just previously about the cruelty involving the Tuskegee experiment with the Public Health Service of the United States. And as previously mentioned, that experiment began in 1932, in which 600 Black sharecroppers from Macon County, Alabama were recruited under the guise of receiving free medical care for what was termed as bad blood. But in fact, as noted, it was really an observational study in nature of untreated syphilis among Negro populations. The study was eventually stopped in 1972 after information was first leaked and then published by the New York Times on November 16th, 1972. Because of events like these and others to follow, it's been noted to be a highly volatile subject when talking about reluctance of trust of the Black and brown communities with the government. We in the medical profession strongly recommend that people take the COVID-19 vaccines, especially in the Black and brown and marginalized communities. We as physicians realize it's going to take concerted efforts from the healthcare community to help make amends for the previous aggressions that had taken place. It will, as I mentioned, take concerted efforts, and this can be done through communication, transparency, and demonstrations of trustworthiness from the medical community. Again, we in the medical community need to create a new narrative that instills confidence in people in taking these vaccines that have been shown to be effective and safe. Once again, we in the medical community strongly recommend that people take the COVID-19 vaccine when it is available to you. Thank you very much.
Thank you, Dr. Burns. Now, we will be hearing the bio for John Snow. Professor John Snow is an associate professor and director of anti-racism initiatives in the Office of Undergraduate Medical Education in the School of Medicine at the University of Louisville. A longtime U of L faculty member, Professor Chanel previously served as a medical librarian in the Kornhauser Health Sciences Library for 16 years and in the Pan-African Studies Department for the College of Arts and Sciences for 14 years. In recent years, his research has focused on the history of medicine and slavery in the United States, including medical experimentation, medical apartheid, health disparities, and the role of medical practitioners and biomedical researchers in the invention of race. Professor Chanel has presented this research at national and international conferences and taught continuing education classes for physicians and medical school faculty. I'd like to introduce to you Professor Chanel.
Thank you, Renisha. I'm going to jump around a little bit in my presentation. I have some notes that I will refer to as well. And my approach is to provide some context for our discussion that follows. And I'll begin with talking about vaccination and vaccination rates. So we've heard quite a bit about vaccination hesitancy, vaccine hesitancy in the African-American community. And recently we've heard about vaccine hesitancy in the population of conservative white male Republicans, 49% of whom have stated they are not willing to take the vaccine. We make assumptions with the term hesitancy as if people aren't really being thoughtful or deliberate in making whatever decisions they're making. In other words, some are making informed decisions and that we should not be judging. And Dr. Burns referred to that as well in terms of the history that African Americans have experienced in this society with the medical establishment. And let me change focus on that for a second. Let me change the lens on that for a second, because we always are talking about the history of medical apartheid, discrimination, et cetera, as if it's in the past. This is a phenomenon that people are experiencing every day, and it underscores the problems they have seeking medical care. So prior to the COVID pandemic, 100,000 African Americans were dying each year due to the inequities in the healthcare system and due to health disparities. So let me be clear about health disparities and healthcare disparities. And I'll start with healthcare disparities and put it within the context of COVID. So healthcare disparities, that term it defines situations where there's inadequate medical care, lack of access to medical care, medical neglect, malpractice, and terrible medical care. So healthcare disparities are consequences that occur from the system and systemic racism in the system that is not allowing African Americans to get access to care, or is giving African Americans inferior care. Health disparities, on the other hand, are the actual experiences that affected persons have in terms of a higher risk for illness, more virulent experiences with illness, and a higher death rate. So when we look at African American communities, for example, there's a higher infant mortality rate and a lower life expectancy. And those two things are connected to each other. These reflect the fact that African Americans are living with the stressors of dis-ease that exacerbate health conditions. It also, what also factors in an immense way, is residential segregation. So African Americans, for the most part, and this is true for the Latinx population as well, live in very few census tracts in this country. Most are concentrated in certain neighborhoods, certain areas. Those areas tend to be those areas tend to be the ones with the highest environmental pollutants, lack of access to good and fresh foods, and areas where people pay more for less. So these compound the health problems that people have. So that accounts for the 100,000 excess deaths. In other words, had Black people, Latinx people, the same opportunities to receive care and to receive equitable care, we would not see that disparity in terms of loss of life. When it comes to COVID, it's estimated that had there been, again, equitable healthcare, even in the midst of a pandemic, there would be 25,000 more African Americans alive today. Over the course of the last year, we lost 25,000 more African Americans than we would have had they received equitable care in this system. So we hear a lot about vaccine hesitancy. What we don't hear about is vaccine apartheid. So to make that term, to clarify that term, initially, when the vaccines were being rolled out, they were staged using age as the measure. So older people would get the vaccine first. In many instances, sometimes health workers were prioritized over others. Well, when you use age as a factor, we know African-American men and women have a lower life expectancy. We also know when this was used as a staging factor, that African-Americans were 2 times more likely to contract COVID and to die from the disease. So in staging that, this was not taken into consideration. African-Americans and Latinx, those are, and Indigenous Americans who have the highest death rates of all and highest rates of infection, none of those were prioritized. So that's a major factor. So then the other part of vaccine apartheid is what happens when actually the vaccines are made available. And in some cases, an attempt is made to provide this service to the most needy and the most affected communities. And what we found is that wealthier people have taken advantage of that situation. So we've heard reports about from people in the Bronx, for example, that people from the west side of New York, some of the wealthiest and most affluent zip codes in the city, were trekking up to the Bronx and getting in line to get the vaccine, displacing the population in that community that was much more highly affected. This happened in LA as well, where they actually gave people codes to identify themselves to give them priorities, Latinx and African Americans in those communities in LA. And come to find out that people in Beverly Hills and Brentwood got access to those codes and were actually getting vaccinated ahead of those affected populations. So this is a major problem that is not did not originate with the pandemic. It is an ongoing concern, and there's a very, very clear solution for it. That's called universal health care. All health is public health. Even though we have residential segregation, walls and gated communities cannot keep out COVID-19 or any other infectious disease. We live in the same environment. We share the same environment. Everybody's health affects everybody else's health. And this is true in mental health as well. And so the solution to this problem is universal health care, and that's equitable health care for everyone. That would reduce the excess death rate of African Americans by 100,000 a year. That would eliminate the disparity in infant mortality, where we see African American infants are dying at the rate of twice the rate of what African American infants experienced in this in the antebellum era before the Civil War. The African American infant mortality rate today is twice as high as what it was in 1860. So despite the fact that medicine has been modernizing, it hasn't really solved the problems that African Americans have because it's modernizing in a system of medical apartheid. Thank you.
Thank you, Professor Chanel. At this time, I would like to introduce Pastor Timothy E. Finley Jr. Pastor Finley is the senior pastor and founder of Kingdom Fellowship Christian Life Center and the chief executive officer of Life Development Corporation in Louisville, Kentucky. For over a decade, he has remained committed to his mission of advancing the gospel of Jesus Christ by faithfully serving his church and community through discipleship, outreach, social justice, advocacy, and empowerment. While thriving in ministry at Kingdom Fellowship Christian Life Center, Pastor Finley is flourishing in many community-based and entrepreneurial endeavors, as well as being the CEO of the Life Development Corporation. He also helped establish and implement various community programs, including Every Little Bit Helps outreach, the Fresh Start Initiative. He founded and established the One Body Fellowship, in which he shares and collaborates with pastors, community leaders, and churches throughout the city to spread the message of Jesus Christ in clarity, integrity, relevance, and excellence. Pastor Finley is also the founder of the Justice and Freedom Coalition and has organized and led dozens of organized nonviolent protests, demonstrations, and voter education drives. In partnership and support of both spiritual and natural empowerment, Pastor Finley is dedicated to facilitating positive change through Christ-centered spiritual, social, educational, and economic. Pastor Finley.
So the hardest thing I've done today is try to follow doctors and educators with those comments. I actually had some notes written out with statistics and going back to the Tuskegee experiment. So that obviously is no more. So I'll just talk about just sort of my own journey when it comes to sort of the vaccine reluctance. We were contacted, and I was very, very grateful for this, by the University of Louisville several weeks ago about becoming a vaccination site. We were one of the first here in the city. And where we came together, sort of our thought was, let's put it out there and try to get about 100 people to this vaccination site. And again, this was somewhat early in the process. This was during the 2 days of snow that we had. So we weren't able to get out and sort of beat the pavement and do things that we thought would drive the numbers up. We weren't able to get out into the community because of all of those sort of restrictions with the snow and then with everything else that's going on. And with our 4-person volunteer call staff and social media, while we were shooting for about 100, we got close to 1,000. And at that time in Kentucky, I want to say that the numbers were 330 plus thousand white people had been vaccinated. And at that time, only about 16,000 Black and brown people had been vaccinated. Now, as this is coming together, before really this is coming together, I'm thinking this is about the apprehension of Black and brown people. And I do absolutely believe that that was a major contributor, no question. But then, you know, I talked about my vaccine reluctance journey. I found out something that I hadn't necessarily really counted on. And we all know that there are equity issues in our city. We see that that is often exacted against Black and brown communities. But I didn't realize when it comes to this vaccine, the level or the desire of people to actually get it. If you would have told me beforehand, I would have said it's apprehension, it's reluctance, because even myself, you know, I struggled back and forth if I should get this. And I know that as a pastor, as a community leader, if I get in the pulpit, or if I get on a social media post and say that I'm getting the vaccine or you should get the vaccine, then there are people that are going to listen to that. And, you know, I had a lot of the usual questions that people had. But again, what really blew my mind was the amount of people who were literally on the phone crying because the way in which this was rolled out was very difficult for people. You know, I have a 90-year-old grandmother who does have a cell phone. It's rather large with rather large buttons, but she does have a cell phone. Her trying to register on her phone for this vaccine in an area where there may be internet connection issues, it was a problem. The other sort of issue that we saw that really became very prevalent as we were talking to people was that there was no plan going into this sort of vaccination rollout. So for instance, myself and a few other pastors have a pretty large platform here in the city. Well, we were contacted by University of Louisville and others really mid-February. Now you would think after 500,000 people have lost their lives, after this has been our reality for over 12 months, knowing that this vaccination was coming, that there would have been a reaching out to Black leaders, to Black and brown leaders on a vaccination rollout. That did not happen. And that brings me back to, I believe that this was not simply some accidental, equity issue. I just, the challenge that I had through this whole process was, for 12 months, we've been hearing about what was coming, what they're working on. We've been seeing that Black and brown communities were disproportionately affected, 2.5 times the rate. We saw these different things, and yet with all of the facts on the table, there was still major equity issues. I believe that now it is very, very clear, looking back on this situation, looking back on even looking at this current rollout, that we have to do a better job, both in the in our churches, and I'm going to speak about that in like 2 seconds, in our churches, and in terms of representation in local government. We have to do a better job of thinking about and bringing us to the table first. It cannot be an afterthought. I think from a religious standpoint, from a church standpoint, and I'm very passionate about this as well, I've seen groups and I've seen religious leaders speak against the vaccine. And I think that is very irresponsible. As a matter of fact, I would go as far as to say that I think it's unbiblical. One of the staple scriptures that we build our faith on, that we trust, it's Jesus as he's answering the question. He's asked, what's the most important commandment? What's the most important thing that we should know? And Jesus responds, and I'm sure people know this, I hope you know this, he says, you shall love the Lord your God with all of your heart, mind, and soul. Then he says, the second is like unto the first. You shall love your neighbor as yourself. This vaccine has taken a heavy toll in our community. People have died. People have, 2020, I did more funerals in 1 year than I've done in my 13 years of pastoring. I think after we tallied everything, I think I did between 40 and 50 funerals in 1 year of people who either died from this virus or lost to gun violence. And I think as people of faith, we have to be careful about our messaging. That's why I couldn't wait to get on this Zoom tonight. That's why I participated in these kinds of discussions, because I believe that if we love one another, if we care about our community, if we care about our grandmothers and aunts and uncles and cousins, then it's our responsibility to do the very thing that can save their lives, and that's get vaccinated. So I see my little time, so I said 20 seconds. I know I'm preaching, so I can talk for hours and all that. So that's all I have to say.
Thank you, Pastor Finley. And thank you all to our panelists for giving us an insight into your experiences, your perspective, and your expertise as we move on into today's topics. Moving forward into the Q&A session of this event for this evening, I would like to remind all the participants to stay muted as we move through, as you have been, and I thank you for that. I would also like to remind you all that if you have any questions as we move forward in our Q&A session, to put them in the chat. We have moderators, our lovely Jess Petrie, Tiffany Gibson, and Gina Genova, that will help me get your questions presented to the panelists as we move forward. But again, we ask that you stay muted throughout the night and that you put your questions in the chat and we will get them incorporated during tonight's session. Also, at the end of this session, we'll be asking you to participate in a survey based on your experiences and your thoughts of not only this session, but what you may have experienced throughout this vaccine rollout and distribution process so far. So without further ado, we'd like to get into the questions. One question that we have lined up, just as a starter, would be, is there anything particular about COVID-19 that makes it more virulent and deadly for so-called minorities? And is there something about these minoritized groups that make them more susceptible to the virus? And again, at this time, we will ask the panelists to chime in whenever they feel ready to.
Okay, well, I'll start. And I know Dr. Chenault and Dr. Lavelle Bruce will have plenty to say as well, too. I'm just going to say that from a physiologic standpoint, there's nothing that makes it more deadly, per person, so to speak. I do believe, however, one of the main reasons that you're seeing it disproportionately affecting the marginalized along with the Black and Brown communities is that the situations that we are in. There are a lot of us that are frontline workers, a lot of us who live in households with several generations, and we're more exposed to this. Plus, also, if you look at from a socioeconomic standpoint, with regards to jobs, a lot of us in the minority community are not able to work from home. We're not able to work remotely, anything like that. We have to be there at work again on the front lines. And when you're there, you're going to be more apt, more prone, more exposed to COVID-19, and thus more susceptible to the actual disease itself.
I'll add that when we're talking about things like medical apartheid and the medical system itself, it's a fact that historically African Americans have been viewed as the vectors of disease, and African American culture has been perceived and basically described as a causative factor in our health disparities. So in essence, there's a tendency to blame the victim and not put this in context. So the context I use is, again, I think one of the most important ones is residential segregation. So let's look at it as in terms of X population and Y population. Y population owns everything. They used to own all the X's. And the Y population decided, we don't want to live anywhere near the X's. So we're going to make sure that they are not allowed in our areas. They used to put up signs to make sure that people stayed out. The signs are invisible, but the same message is there. The Y community has access to the best food, healthcare, transportation. The businesses, et cetera, are primarily around their communities. The people in the X community have to pay more for everything. They have to pay more to get to work because the jobs are not in the X areas. They have to go to those other areas. They have to go to those other areas to shop, to buy food. Their educational system is inadequate. All these things factor in terms of their experience of disease. And let me give one other illustration. When I made the comment about the more medicine modernizes, it doesn't change this situation that we have. And that's, again, looking at where the X people live and given their lack of access to resources. Let me just give one example of what I'm talking about, and that's cervical cancer. So before the diagnostic tools existed for cervical cancer, African-American women and white American women died at about the same rates. The reason why, there was no early detection of it. So by the time many women went to and presented, their problems to the doctors, they were well in advanced stages of cancer, which was, deadly for them. It proved to be a major factor in the death rate. The more advanced the cancer is, the more difficult to treat. Well, once early diagnostics became available, the Y community was informed about the availability of it. They have regular access to healthcare because they also have health insurance. And so they availed themselves of the testing. They availed themselves of the diagnostics. So we see a decline in that death rate in that population, but there's no movement for African Americans. So this is what I'm trying to illustrate in terms of the lack of equity there.
Definitely appreciate what you both shared. And I think this question makes me think about how important it is to understand implicit bias, which has to do with, holding thoughts and feelings about minoritized communities, but not being aware of those things. So holding negative or, prejudiced views, but not being aware of that you hold them, and then going into the office and treating these folks and not being aware how that bias impacts how you treat, intervene for communities of color. And so I think that it could be very easy to, like you were saying, to kind of blame the victim. But I think what is becoming more of a topic, especially in the mental health care field, is this idea of what cumulative experiences of racism and discrimination and injustice do to the bodies and the brains of people of color. And what we know, which is what I shared earlier, is that when you experience these types of injustices over and over again, it starts to kind of link, almost like taking a bunch of bricks and kind of piling it on the individual. And the doctors can speak much better to the body's stress response, what happens when you have too much cortisol and all those types of things. But that's why oftentimes we see a lot of health care or health disparities and higher incidence in our communities Like you were saying, you all were saying not having proper access to food, being in food deserts, being in, positions where we have to be in face-to-face positions and not having the ability to call off from work, because if we don't go to work, our families won't eat, and all these types of things. So I think that, I appreciate you all saying that there's nothing, biologically inferior about, people of color. But, we have to really talk about all the things that y'all mentioned, as in addition to the fact that racism and discrimination, it's like a bunch of bricks laying on our bodies and our minds, and it has an impact on our ability to cope mentally and also physically as well.
Can I add too, and I completely agree with everyone. I think when you talk about inferior, I use that word inferior, I certainly don't believe that we're inferior at all. I do believe that our neighborhoods were designed to be inferior. I think when you talk about the social determinants of health and how that's had that effect on us with redlining, and the fact that our neighborhoods were purposely put into industrial areas where we're having to breathe in chemicals, even here in Louisville, Rubbertown. I think one of the things that's very important is that we understand that what we would refer to as the hood, or some would refer to as the hood, the ghetto, they didn't just come because that's where we chose to assemble. They were purposely designed across the country to herd Black people into certain areas. And many times those areas, again, the quality of life, the environment, the air quality, even the soil, all of those things were very much determinants. So I think we talk about inferior. No, we're not inferior. But the plan in America has always put marginalized people in a terrible position, so that when a once in 100-year pandemic like COVID-19 comes along, it is not a surprise, and it should not be a shock that we would be affected the way that we are. Because again, we've always been susceptible to those kinds of pandemics because of the way that we've been marginalized and treated in this country.
And to add to Reverend Finley and Dr. Chenault's comments, just so you know that when we talk about chronic diseases, hypertension, diabetes, renal, kidney disease, these are very prominent amongst the Black minority communities. And a lot of it is responsible for what both Dr. Chenault and Reverend Finley were pointing out to, just our environmental exposures to that. Again, having those chronic diseases puts us at higher risk, not only for attaining COVID-19, but also having bad outcomes from the disease.
In actuality, what we're experiencing now is what I observed in Africa years ago. It's called the double burden of disease. So you compound in an environment where there's a lot of infectious disease, and this is what I encountered in Africa, particularly malaria. And then all of a sudden, they're adopting Western diet. So there's hamburgers and all this kind of stuff. There's Kentucky Fried Chickens outlets popping up, right, in big cities in Africa. And so now we see the double burden of disease. I mean, malaria is awful in and of itself, but then you add hypertension to it, and you add heart disease, and you also add cancer to it, which was, very, very minimal factor in some of these societies. So this is what African Americans are dealing with constantly, is this burden of disease, and it's not something that society as a whole is concerned about. If society as a whole, and that means the government as well, was concerned about it, then we would have access to healthcare for everyone in this country. And again, I really want to drive this point home. You can live in a walled community, but that does not protect you against COVID-19. It does not protect you against these infectious diseases and these pandemics. And let's be clear. Now, Dr. Burns referred to this as a 100-year pandemic, and he is absolutely correct. But if we go back in history, pandemics were happening on an annual basis in this country throughout most of its early history until some measures were taken to improve sanitation, public health, et cetera, et cetera. The fact is we could be entering into a new phase of that. And we should be thinking about that in the long term. Because of climate change, that's a major factor in this. In terms of infectious diseases and zoonotic diseases, insect-borne diseases in particular, and just recently we had a report of a new species of mosquito in Florida that carries encephalitis. All right, so these things can run rampant through populations. And if you're living in Rubber Town and these polluted areas with lack of access to healthcare, lack of access to good food, et cetera, you are at a higher risk than everyone else to succumb to those when they come and when they occur.
So Professor Chanel, we have a question in the chat that I would like to present to the group that I believe ties into your proposal of universal health care. And our guest, Erica Gresham, asked the question, if we had a better universal healthcare system, do you think that would encourage BIPOC people to want to take the vaccine?
Well, I think that if we had a better universal healthcare system, there wouldn't be any question that people would have access to that care. So I have a friend that lives in France. Whenever she needs to have an exam, the doctor calls her, sends the email or whatever. When it's time for your pap smear, your breast exam, and they go in and they have the exam, the doctors are contacting them, telling them what they need, when they need it, if they need vaccinations, et cetera. And then when they go in and get treatment and service, it costs like $8 or $10, some minuscule amount of money. So it's a combination of having access to care, but also having access to care providers who look like you too. So that's another factor when African Americans seek care. They're suspicious and they're distrustful given the history of this country. And so part of alleviating that is to diversify the healthcare providers so that people feel comfortable, that they identify with folks. And this is vital. Our infant mortality rate is tied to the fact that many of our children, our infants, newborns, are delivered by white doctors. And there's a major study that just showed that they have a 30 to 40% increased rate of survival if they're delivered by African-American physicians. This is criminal. The same statistics show there's no difference when African-American physicians deliver white babies. There's no decline in care. There's no increase in their death rate, but the reverse is true. And this was based on a study of 1.5 million births. This is a massive study. So what makes that difference in that situation clearly is having African-American healthcare providers. So universal healthcare and diverse healthcare providers in combination, I think, creates an equitable system where people can get the care that they need.
If I could add to that, I just wanted to say that I certainly read the same study about the mortality rates among pregnant Black women and how having a person of color, particularly a Black woman or Black person as a doctor, really does help to improve those outcomes. There's also a lot of research that shows that, I think this is why implicit bias is so important, because when you outwardly say that you are for equitable care and are, that you want, equitable services among racial groups, that's one thing, but you may be practicing in a way where you are not giving the same services across patients. And so there's research that shows that, people who are practicing, particularly white doctors, may perceive that people of color who come for services or for treatment are less compliant, and so therefore may not treat in the way they would a white counterpart. There's also studies that show that there's perceptions that people of color, particularly Black people, will not follow through on those interventions. And also there's other research that shows that there's a perception that we handle pain differently, that we don't feel pain in the same way that other groups do, particularly white groups. And so those are some of the other factors that I think go into bias, and that I think that these things have to be talked about and acknowledged so that providers can really start to understand their own bias to check their own bias, and so that they can give culturally responsive care to all people. And I think if those things are not recognized and talked about, that we're going to continue to have this problem. Because if you don't recognize that a problem exists, or you deny it, or you do, practice erasure where you deny that anything has ever happened, and that everything is fine now, there's no fixing the issue.
On the issue of pain management, so African Americans are underprescribed pain medications, analgesic narcotics. This is a massive problem for sickle cell patients in particular. One of the primary symptoms they experience is pain, and severe pain, and they're treated as if they're drug addicts when all they're trying to do is get care and treatment. But even more so, this idea that African Americans have a greater tolerance for pain goes back to enslavement, right? That's part of a medical mythology that still lives. It lives to the point that there was a study done. This is all I do is look at all this stuff, right? There was a study done a couple of years ago, which showed that because African Americans were being severely under-medicated, 30,000 people are alive today that would have died during the opioid epidemic because they were not prescribed opioids by white doctors. So let me make sure this is clear. The fact that African Americans were being underprescribed and getting inadequate treatment from white physicians saved approximately 30,000 lives. So that tells you what happens when we go into the system. Many times we go in relatively healthy and come out on a gurney.
Wow, that is amazing. The conversations that we're having about the access and what that looks like in these communities is crazy. I would like to segue into another question that we have for folks in the group. Let's see, we have a guest that asked, what is the best way to advocate for vaccine uptake in the BIPOC community? Should we be targeting attitudes, or should we focus on removing barriers, such as increasing access within the community, perhaps? I know Pastor Finley said that he had the opportunity to be first sites within his community, and the issues with access that he encountered. So I wanted to know if he would like to chime in on some of the things that he encountered during that distribution process.
Absolutely. I think to the question, I don't know if the focus on attitude would be the direction that I would go. I think a lot of it is just access. I think that one of the things that I was very careful to do, I didn't want the University of Louisville to set the mandate for how we organized it and sort of how it came together, because I know that we know the community, we know the people in our congregations, we know the people in our groups. So we wanted to put the vaccination site not in a classroom or not in an area of the church that isn't used frequently in a classroom. We wanted to put the vaccination site where they're getting it, right in the middle of the sanctuary, a place where many people feel safe. They, there's a level of trust there. It should be, and those are the kind of things that we wanted people to know. This is something that we're doing. We're putting it in a familiar place, and we believe that it's safe. Something else that I did early on was that I took the vaccination, did it, on the news with other leaders, because I felt that if I'm going to have any influence, or if I'm going to have a platform, to whom much is given, much is required. And after really feeling that this was the way to go, I was okay with doing that. As a matter of fact, I did that with my mother. I was invited to do it with the news station, and my mother is 68, 69. And I think that as leaders, we have to use our platform correctly. But I don't think going after attitude, we're intelligent enough to make our own decisions. Even related to the last question, we talked about the sort of debunked myth about Black people and pain and things of that nature. I have this bust on my shelf there, and it's a study on phrenology, which is now a debunked sort of study, which was used, if you all remember Django Unchained, Leonardo DiCaprio's character went through a whole thing with that. I put that there because it sort of motivates me, because for the person that put that out, that particular, and again, I'm on a Zoom with doctors and educators, so I dare not even try to go down the road. So if I say something wrong, you all help me. But that particular doctor tried to push this thought that we were mentally inferior and that we could be controlled through certain manipulative surgical procedures. And I put that there just as a motivation. I think a lot of that, we talk about, even when it comes to should we go after their attitude, it reminds me of hints of that we're not intelligent enough to hear the science and make informed decisions as every other group is being allowed to do. We don't have to be cajoled, we don't have to be manipulated, and we don't have to be enticed to do certain things because we're somehow inferior in our thinking. So I try to stay away from that. I try to use the platform, make access easy, and then allow people the dignity of making the right decision. And I think people are doing that.
I agree that access is the preeminent issue. We are seeing few vaccination sites in Latinx and African American communities compared to others. Access to the vaccinations is obviously racially biased. So I think access. I don't believe that African Americans, as Pastor Finley said, need to be cajoled. You know, when you have seen people in your community dying every day, I don't know what's more persuasive than that.
I would agree. I think early on, before the vaccines came out, there was maybe mystery or people were wondering about it and might have been, again, vaccine hesitant initially. But I think once the vaccines rolled out, people were taking them. And then, of course, we realized there were barriers to overcome, as has been previously mentioned, signing up, to have to do that electronically, when some people may not even have a computer or a smartphone or Wi-Fi access, but overcoming those barriers, providing the vaccine. If you can't go get the vaccine, let's bring the vaccine to you, which is actually, I believe, what the president has been advocating, with having number one, more vaccinators. Number two, having like mobile units that will be showing up in communities. Number three, pop-up sites, as Reverend Finley mentioned, his church participated in. And again, as Dr. Chenault also mentioned, just having vaccine availability. I think all that's changed the entire narrative on this. In addition to leaders and physicians advocating for this. I really believe that's made all the difference. And I think as vaccines continue to be rolled out, not only in those areas, but also to, for example, the pharmaceuticals, Walgreens and CVS, and also I know they'll be coming to private physician offices and other community centers. I think it's going to be there, and I do think the Black, Brown, and marginalized communities will participate. Of course, there's going to be holdouts on every group, any kind of group you can mention, but I do believe the vast majority will participate.
I also agree. I think that, instead of talking about the attitudes of Black people or people of color in general needing to be shifted, I would say, attitudes of those providing care. And I think for me, it has been very helpful to have and see the increased representation of people of color who are, helped with the formation of this vaccine, and also seeing people in my community who have influence and power, such as pastors and government officials, doing it, taking it, and showing that allowing us to see them take it. I will tell you, when I saw the President Biden take it and other folks, white folks, that really didn't do too much for me because I thought they have access and privilege that I may never have. But when I saw people in my community and talked to people, doctors who I knew had my best interest at heart, that really helped me to move in a different direction and decide to take it. And so I think having more representation of color is extremely important. And not only for the vaccine, but just in general of teaching our young people what they can achieve and what they can do in terms of creating life-saving, medicines and drugs and that kind of thing. So I would say representation is very important.
And also to add to that as well too, debunking any myths that may be spread out there through social media or whatever, however. Telling the truth, being honest, being transparent. Again, myths, just debunking those, I think would be extremely helpful as well.
That applies to the vaccine itself. And Dr. Burns, correct me if I'm wrong about this, but I believe that the measles vaccine was the most effective vaccine that had been developed to date, and that there are very few vaccines that have the efficacy of the measles vaccine and the COVID-19 vaccine. So these are not some kind of fly by night or haphazard, or I don't know what you want, jury rigged or whatever you want to call it. This is a phenomenal achievement on the part of the manufacturers of these vaccines, and we should be extremely appreciative of what they've accomplished because they work. That's the other important thing, and they work with. Let me say this too. Moderna and Pfizer had the best clinical trial pool that I've ever seen for a drug trial. 10% of the people in those pools were African American and minoritized people. You rarely see that in clinical trials.
That's absolutely correct. Absolutely correct. And even the Johnson & Johnson vaccine, although people look at numbers, Johnson & Johnson vaccine, just to, not to sway the conversation, but just so you know that the Johnson & Johnson vaccine had to deal more so with variants as opposed to the Moderna and Pfizer, which for all intents and purposes dealt with the what we call the wild type or the basic primary type.
While we're on the conversation of variants, I wanted to interject a question. So when we talk about the safety and efficacy of vaccines, how does that relate to these COVID variants? Are they dangerous? Should we be expecting yearly boosters, looking ahead with COVID?
Yeah, the science is still early. There are some things that are factual. For example, when we talk about the variants, there are three major variants that have come from overseas. The B117 variant from the United Kingdom is probably the one that's actually even more contagious. And now we're slowly but surely finding out that it is becoming much more deadly and associated with higher morbidity than was previously thought by us here in the US. But again, that one is much more contagious. The other two variants I'll just mention real briefly. The B135 from South Africa, and the P1 that was initially from Brazil. Those are the major ones. And fortunately, we haven't seen very much of those. We've seen them here in the U.S., but the B117 is the one that is much more contagious, much more prominent of all the variants. The good news so far is that our vaccines are still working against all the variants. And even the what I call the homegrown variants here in the U.S., the 427 and 429 from California, and the 526 from the New York area. But again, the vaccines are effective against those. Just to real briefly mention that viruses like to mutate, and eventually, if these viruses left unchecked, that is, people not getting vaccinated, the viruses will work their way around the vaccines. The vaccines, unfortunately, the viruses will become impervious to the vaccines. So that's why it's incumbent of all of us to get the vaccine, to get to a point where people are immunized and this virus has no place to go to replicate. Because as I've said hundreds of times, I'm sure a lot of people have heard me say it, if the virus, if it cannot replicate, it cannot mutate. And so that's why it's really important for people to get the vaccine.
So speaking to the vaccine distribution as it stands, where are we currently and what does that look like for the communities in our area when it comes to distribution? What are the numbers? Are there going to be enough vaccines available for people as we move on into the larger groups where more people will be wanting these vaccines?
From what I know, from what I understand, again, I think the vaccines are becoming and are much more readily available now than they were 2 and 3 months ago. So I do believe we're going to get to a point where you're going to see, for lack of a better term, a flood of these vaccines everywhere, which will be great. That way, you actually hear people talking on the news now about, you could probably go somewhere less than 5 miles from your home, to get a vaccine. Of course, 5 miles is still a pretty long distance, but I think what's going to happen again, that vaccines will be much more readily available, where people won't have to go very far from the home, and if they can't go to a distribution center, to a pharmacy, again, the government will provide mobile units for in those areas where transportation is a much larger barrier, and again provide that is bringing the vaccine to the people. Again, that's from what I understand. And in addition, they've raised, right now we're at a point where I believe it's age 40 on up can get the vaccine, and I believe very soon, in the next week or two, they're just going to open it up to everyone above the age of 16 to become vaccinated.
I have some data on vaccination rates, but it's February's data. And as Dr. Burns pointed out, they're rolling this stuff out everywhere now, and it's changed in terms of the ages. It's more available for younger people than it had been in February. But as of February, the rate of COVID-19 vaccination across all states with available data is only, the African-American vaccination rate is only 12.7%, which is the second lowest of all racial and ethnic groups, the lowest being Latinx. So as of February, 12.7%. New Mexico leads all states in vaccinating Black residents with 18.8%, Louisiana 18.7%, and North Carolina with 18.1%. There are many states vaccinating less than 10% of their Black populations, and the worst are Iowa at 3.2%, Pennsylvania 3.3%. Those were the lowest rates for African-American residents. Now, one of the biggest problems we have is lack of ethnic and racial data. So many states were not looking at or breaking the data out on the basis of race and ethnicity. That's true for mortality statistics as well. So in many cases, we don't really have an accurate measure of who's getting what and who's not, who's dying and who's getting better. I think the other thing is that the country as a whole, if we look at the total numbers, which are now in the 550,000+ range, that is not true. That is vastly underestimated, because many times people who died at home are being classed as having respiratory, failure or heart failure, et cetera, and that COVID is not part of the death certificate. information, so it's not being counted. This happened in nursing homes as well. So we don't really know how many people have been infected, how many people have died, and we don't have a breakdown by racial ethnic groups. In the 21st century, we don't have the data.
Can I ask a question of the doctors? Can you all hear me pretty good?
Yes.
Okay, good. Because it was a question that I had with this vaccination rollout. And it also sort of supports a theory that I have that America, and even here in Louisville, we romanticize the ideas of equality, but we resist equity. And that's where I think we often miss that equality and equity are two different things. When you talk about the vaccination rollout and the ages in particular, if we know that going into this, if we know that Black and Brown communities have been affected at 2.5 times the rate, if we know the numbers support this, I did not understand, and this was a conversation I had with U of L, and thankfully they were able to create some level of wiggle room. Other groups that we had contacted and that had contacted us were not willing to adjust the age. But I never understood why, if the data supports that we're being affected at this rate, why come out with the same age threshold across all people? And that's Black, white, whatever the case may be. It was my thought that if you have these equity,
Thought I lost you there for a second. If people were being affected,
then why not have an adjusted age for Black and Brown people and a different age for white people? And I think on its face, I think it's equality. It's that, no, we like equality. We stay away from equity, because I think equity is difficult for Americans that are committed to their supremacist and superiority mindset. But I don't understand from the science, if we're going to roll this out, why not come out with, and this may sound a certain way, and I hope people hear my heart, for white people, 70 years old, that's great. But for Black people, 40 years and up. I'll give you an example. I spoke with a friend of mine at a church, a very large church here in the city, one of the largest Black church in the city. And they were doing a vaccination event, but they weren't with the University of Louisville. They were with, I guess, a competitor. And they were turning Black folks away who were 68 and 69 with pre-existing conditions, but they were turning them away because they weren't 70. And for me, I don't understand the logic of that. So I'll ask, what was the thought behind that, and why is there such equity issues within the vaccination rollout, if you have an answer to it?
Unfortunately, I wasn't actually privy to the process or how they would, even when they came up with that. That's actually, I think, it was from the government, from maybe the president, but definitely the here in the Commonwealth, the governor's office. Those breakdowns of those groups was sent from Frankfurt. I know that for sure. But now, with regard, I agree with you 100%. I've always been of the mindset, and I'm sure most people will tell you, there's a saying that you never turn anybody down to get a vaccine. Okay, I mean that's to me that's kind of cruel, and especially if you're splitting hairs 68, 70. To me, it makes no difference. Actually, Jason Smith had made comments. I'm on a committee with him, and he said that with U of L and eventually Norton's and Baptist East, all of them agreed that they weren't going to turn anybody down. If they came in, and that's what they and they were there. They weren't going to turn anybody away from the vaccine. I don't care if you're in your 20s. If you came and you got for a vaccine, they wouldn't turn you away. And of course, you look at nationwide, people look at numbers, parameters, and they say, well, we have to be strict with this and that. I agree with you 100%. I know if it were me.
Jason's point, to Jason Smith, to what you just said, that is very true. Yeah. Because Jason was very out the gate. He said, we're not turning anybody away.
Right.
So I know that we were doing, we had the threshold of 65 and older. And a kingdom, that's just me. We pushed it. So I mean, we were doing 40-year-olds, 30-year. I mean, anybody. We said, bring your family up here. And I think that there were language things as well, because, and I meant to say this earlier, when we first had the conversation, it was, we want to vaccinate your congregation. Well, if you're familiar with our church, 85% of our congregation is millennial. Like I said, my mother is 67, 68. She's probably in the top 5 oldest people in our church. We barely even reached the 70-year-old threshold, which means we would have qualified for about 2 or 3 people to get the vaccine. To U of L's credit, to Jason Smith's credit, one of the things that I said to them was, don't use language, because some may not push back. They may just say, okay, this is just for our congregation. For us, we said, for the purposes of being vaccinated, every Black person and every brown person in Louisville is a part of our congregation. And we just went blanket social media. And I even had people that said, well, you shouldn't do that because it's going to be a free-for-all. Well, we can administer when they get there. We want a free-for-all. And that's what, I think that's why we got from 100 people to 1,000 people in 3 or 4 days. So
right, and I think them coming from the area was the important point. In other words, again, still don't want to turn anybody away from a vaccine, but you would prefer to have people from the West End, the 40210 zip code versus the 40242s, the 40205s, East End and above, because there's access for them. But remember, we're talking disproportionately in minority communities. So that was the hope and the purpose behind that. So again, I if it were me, I would never turn anybody away for a vaccine. But I think it's a case where they said that to keep people from the East Side coming down versus the reality of it, which was just vaccinate whoever comes.
Well, and I'll say this and I'll be quiet, but I actually had to get up and do a Facebook post the next day when we first put this out there, because the first day we had, hundreds of people that called in, and we were taking zip codes. Well, I did the Facebook post because we started seeing people call in, large amounts of people from Oldham County, LaGrange, Lexington, Northern Kentucky, where I had to actually go on and say, we want everyone to be vaccinated, but the truth is we're concentrating on those who have been affected by this. So that, to your point, that's absolutely true.
I just wanted to add to that. Oh, I'm sorry.
I'm sorry. We are coming on time. So I have one final question for everyone. Is like a round robin thing, right? And I hope that the question that I pose will be able to give everyone the opportunity to speak on their pressing final thoughts, right? So we wanted to ask, before we let the majority of our guests go for the evening, and thank you all for your time, what can the medical field do to improve upon its relationships and foster trust within communities of color? And beyond that, what is it that the community can do as well to kind of encourage ourselves within our communities to foster that trust within the medical community?
If I could, I just wanted to respond very quickly to what Pastor Finley was saying. And I think as a psychologist who studies oppression and white supremacy, I think it's important to mention that, any white supremacist system is going to protect the majority and privileged groups while simultaneously disenfranchising people of color. So it's not surprising to me that clear data that shows where resources need to be targeted would not be targeted in order to maintain that system. That is something that historically we've seen in our country and others. Renisha, I think your question had to do with what can the medical community do to improve relationships? Is that correct?
Yes, to improve relationships and foster that mistrust.
Right. So we've all talked a little bit about the importance of representation and seeing people who look like us in the medical field. And I think that seeing that on social media, seeing people who helped to create this vaccine, being able to talk to professionals who share identity with you is extremely important, because when you see people who look like you, you are more likely to feel like they understand your unique concerns. And to not only that, but to understand the barriers that make it difficult for you to engage in services. Another thing I think that is very important is this idea of erasure, or this idea that, what the things that we've talked about for centuries that have happened to Black people, people of color in general, to act like those things didn't happen, or to rewrite history. And so to have people talking about acknowledging the harms and abuses that have happened are very important, so that they can, again, if you don't acknowledge something, then you can't do anything about it. And so when you talk about it, then that creates a space where medical schools and healthcare professionals, people who are training healthcare professionals, can really talk about and train folks how to provide culturally responsive care, so that these biases that I talked about earlier are not wreaking havoc on our minds and our bodies. When people go into a helping profession, they need to understand how they think, where their biases came from, and then work to counter those with the truth, and let go of these myths and these biases and racist views, so that they can really give adequate and equitable care to all people, particularly people of color.
Yeah, I just want to say everything she said. That's pretty much, yeah, 100%. I won't follow that. I totally agree. I also think bringing us to the table earlier is so important. And I think that amounts to trusting, recognizing, and seeing and respecting leadership within our community, and creating a synergy and the ability to work together to overcome many of these obstacles. But again, Dr. Bruce said it perfectly, so absolutely.
I'll say that the biggest problem and biggest challenge we have is the medical establishment is leading from behind. So the powers that be in medicine, American Medical Association, the Association of Colleges and Universities, the American Association of Medical Colleges, the accrediting body, well, those two first, the AMA and the other, AAMC, they have a long history. AMA was founded in the middle of the antebellum era, 1843. The AAMC, which represents medical colleges across the country, was founded in, I believe, around 1896, and it consisted of all the white medical deans of white medical schools. These are the people who set the agenda, and they have been leading from behind. 70 years ago, UNESCO, the American Anthropological Association, the American Physical Anthropological Association called for a massive change to move away from treating race as a biological construct to a social construct, to understand that race has a history. It is not something that is biological, evolutionary, et cetera, et cetera. 70 years ago. By the 1990s, those organizations were acting on that. In November 2020, we're talking months ago, the AMA finally announced a policy to move medical education to post-racial medical education. So that's the problem, and that's the challenge. So we are a long way from dismantling systemic racism from our medical institutions and healthcare systems, because the medical establishment is leading from behind, is really adhering to the status quo and looking at change as not an opportunity, but as a threat.
I'll just say that kind of goes back to what I said at the very beginning. I think number one, from the medical standpoint, we should acknowledge the previous transgressions. Secondly, I think we need to be extremely transparent in things we do. And then also, I believe communication is key. People that may have anxieties about things, talking with them, speaking with them, telling them the truth, the facts, debunking any myths, being totally honest and upfront. And whether the news is good or the news is bad, not candy coating things, not dancing around things, but being direct, telling telling it like it is. And I believe that would make the difference. Just like if you were interacting and you were establishing a relationship with someone for the first time, these are the types of things that you would do to foster trustworthiness, which I think it's incumbent upon the medical community to do.
Thank you all. I am so grateful to have the opportunity to moderate this discussion with you esteemed and highly expertise panelists discussing and exploring abuse, access, mistrust, and equitable distribution. I want to put out there that there is a quick survey in the chat if you're still with us. If you could graciously fill that out and let us know how we did and what we can do moving forward. And looking forward to the rest of the series in healthcare, diversity in healthcare series that we have at the University of Louisville's Kornhauser Health Sciences Library. Again, thank you to Dr. Burns, thank you to Dr. Bruce, thank you to Pastor Finley, and thank you to Professor Chanel for your expertise and your truths. We thank you all for participating in our event tonight, and we look forward to more vaccine conversations, as this is a very timely and important discussion.
Thank you all for having me.
Thank you.
Thank you for having me.